So welcome everybody to the second lecture on solving the toll of depression on populations. You may have seen my first lecture on prevention of depression. This one is really about making interventions more available in different ways so that more people can benefit from the knowledge that we already have. And I think digital interventions will play a very important part in getting treatments to the people who need it. And I will briefly, because each of these lectures can be listened to separately, so the audience will be not exactly the same for all lectures. So I briefly want to introduce again, the disease burden of depression. Why is this topic important? Then I will talk about internet interventions for depression. And I will show you that digital interventions through the internet are just as effective as other interventions. And that knowledge, we know that from many randomized trials now, that knowledge can be applied in all kinds of different settings across healthcare and outside healthcare. And I will show you all kinds of examples where all kinds of experiments are done now. This is not a finished story because the developments in this field are going so quickly and there are so many new opportunities to make better treatments, make them better available. And I think this is one of the very promising areas which can really contribute to a reduction of the disease burden of depression on a population level. And I will also give a few of the examples of the projects that I have been involved in. And I will also finish with with a few recommendations for future research. So, briefly, depression is a huge public health problem with millions of people suffering it all over the world. Most of them live in low and middle income countries. More than 5% of all years lived with disability caused by all health conditions are caused by depression, and it's enormously costly. And what you can see from this graph is that by far the majority of the disease burden is in low and middle income countries. What you can also see from this graph is that depression is a disorder of the working age. Unlike heart disease, cancer, diabetes, general medical disorders, which are more prevalent in old age. And this means that depression is a disorder of the working age, making it very expensive, $1 trillion per year production losses. Sometimes people say, well, that money, if we can use a fraction of that money to develop treatments, that would be a very cost-effective way of investing money. We did one study with Dan Chisholm of the WHO, in which he used our databases to see what the return of investment is of building up mental health care in low and middle income countries. And he found that for every dollar you invest in the building up of mental health care, the return on investments is $3 to $5. So this is really a impulse for the economy if you build up mental health care. So treatments are effective, not too effective, but the uptake is low. In fact, only a small minority, mostly white, rich, highly educated people in high-income countries use mental health services. And many minority groups, other age groups, adolescents, older adults, people in low and middle income countries hardly have access to mental health care. There have been modeling studies showing that the impact of the treatments we currently have on the disease burden of the population only in optimal conditions where everybody with a disorder gets treatments and everybody gets an evidence-based treatment, only 33% of people with it, we can reduce only 33% of the disease burden in these optimal conditions. So what do we need? We need basic research because we don't understand what depression is. And we really need more understanding where it comes from, what the causes are, and what changeable conditions are to change it and prevent it. But in these lectures, I focus on more clinical approaches. What can we do now to reduce the disease burden? Well, first, we can try to prevent the onset of depressive disorders. And my first lecture was about that. This lecture is about simplifying treatments and better dissemination about dissemination of the knowledge that we already have, getting it to the people who need it. And the next lecture will be about more effective treatments, because that's another option, that we can make better treatments than the ones we have now. So now we're going to talk about, how to simplify treatments and how to disseminate them. So it all begins with the question, okay, internet interventions, when you apply them through the internet, are they effective? Are they, how do they compare with individual or group or face-to-face therapies? And we first have to take a step back to look at the effects of psychotherapies in general. And we did a very large network meta-analysis, more than 300 trials, comparing all major types of therapy with each other, with control groups, so that we could examine which therapies are effective and how effective are they. And what we found, basically, is that all therapies had comparable effects. We found no significant difference between therapies, except non-directive supportive counseling, but that could be an artifact because that's often used as a control condition. So except for that, all therapies have comparable effects. In the literature, this phenomenon is known as the dodo bird verdict, saying that all therapies work and that they all have comparable effects. You can look it up in PubMed, and you will find a lot of hits when you search for dodo bird verdict. And if you do a meta-analysis, does that actually mean that all these therapies are indeed equally effective? Well, we're not certain. There may be small differences we don't know. Or it could be possible that 300 studies with all these differences, and we throw them in a blender, and then you get one big answer to all these specific things, and that may obscure all kinds of more subtle differences. And so we're not certain. But the question here is, okay, if roughly all these therapies have comparable effects, what do we need at least for a therapy to be effective? Can we take off parts of it without reducing the effectiveness? And what can we take off? Can we simplify it? Can we make it easier, simpler, shorter, briefer? And that's, from a public health perspective, that's the most interesting question that can be raised. And if you think about simplifying treatments, well, you can do that in all kinds of different ways. So recently there is this development for single session interventions. That's also done to reduce the dropout, especially from digital interventions. So what you do is you say to people, okay, we have a very good intervention, and we can summarize it in one session. And if you need more, you can have another session. But the treatment itself, the core, is in that single session. And there's quite a lot of research showing that these single session interventions also work. You can say, okay, we are gonna develop interventions which are not delivered by highly trained clinicians who have to go to university, who get trained, who get licenses and have to do all kinds of things. But we're gonna ask lay health counselors to deliver them. That's also a way of simplifying it, and which is done especially in low and middle income countries, but also often, for example, in Holland, we also work with them, in refugees. Yeah, what you do then is you train nurses, for example, in primary care centers, how they can deliver psychological treatments. And another way to simplify treatments is to develop guided self-help. And that means that you explain to a patient in a book or on the internet or with another medium how they can apply a psychological treatment to themselves. And the guided part means that there is a professional, a coach, somebody helping them to work through this self-applied treatment. And nowadays this is all done through the internet. So that's why these are digital internet interventions with coaching. But it used to be done. It started in the 1960s already. So there were books where people could learn how you can apply a psychological treatment to yourself. And then there are studies from the 1960s in which people recorded the instructions for exposure on long play records and tapes that patients could take home and then learn how they could apply exposure principles to themselves. So the principle of digital interventions is not very new. It's the idea that we apply it through the internet, that's new. But the idea of guided self-help, that's something that has been examined for quite a long time. And so then we get to the question, okay, digital interventions, do they work just as well as individual or group therapy, or are they somewhat less effective? For global mental health, that really, or from a public health perspective, that's not a key issue, because I will come back to that later. If you have a large population which does not get an intervention, and you have an intervention with only a tiny effect, but you can get that to very large groups of people, then the impact is enormously. But it would be even better if we would have simplified treatments which are as good as individual or group therapy, because then we can apply this in a more efficient way and we can help more people for the same money. So we did a network meta-analysis of treatment format for CBT in depression, and we looked at individual, group, by telephone, guided self-help through the internet or not, or unguided self-help, compared to the waitlist, care as usual, placebo. And what we found, so we had 150 studies. What we found basically is that any format is effective, as long as there's human support. So we found that there is no significant difference between group, individual, guided self-help, telephone interventions, as long as there is human support. If there's no human support, the effects are significantly smaller. I will come back to that too. Dropout was higher in digital intervention. So if you apply this, you really have to watch out that people don't drop out. And is that only true for depression? No. The same was found for panic disorder recently in a paper from Davide Papora. Basically the same thing. Digital interventions just work. Well, the question is, who delivers these interventions? Because if we still need to invest all this time in clinicians and they still have to deliver these interventions very intensively, then the benefits are not that great. But basically what you do is you give support to people getting these interventions, which is a weekly email, which costs 15 to 20 minutes because it's all structured and it's all, it's all made very easy. And personally, I think if we start doing this with AI, it can be reduced even much further. While it's still human, because it's a human who reads it, checks it, and changes things, add things, and it's still that person that gives this feedback. And in our studies, for example, in the Caring Universities project, we work with trained clinical psychology students who do that. In the UK, they have developed what they call psychological well-being practitioners, who are also not fully trained clinicians, but who get a training for half a year to deliver guided self-help. Okay, so digital interventions work. That's so clear, there's so much evidence. But what can we do with that knowledge? And that's now the challenge, how to get that into the situations where people can benefit from it. And you can think of all kinds of applications of this basic knowledge that these interventions work. You can think of prevention, because prevention should be low threshold, should not cost too much money. You can think of all kinds of treatment centers which don't have a location, which don't have a building where people go to, but which are completely virtual. And there are all kinds of examples now here in Holland, but also in Sweden and Australia, where you have these virtual clinics for treatments. You can think of primary care, where GPs are still often inclined to just prescribe antidepressants. Why not offer a digital intervention before prescribing antidepressants? You can think about specialized mental health care, where you could do just face-to-face therapies, but also deliver all kinds of modules in a blended way in which you, for example, a social skills training or whatever you do digitally, while you still have the face-to-face contacts. You can think of general medical care, where you screen people and offer those who are depressed all kinds of digital modules next to the usual care, the usual physical care they get. You can think of schools and colleges where you screen students and offer the ones who score high on depressive symptoms, digital interventions. The same in the workplace and global mental health. And I will come back to that later. So I've been involved in about 75 randomized trials over the past 20 years, and half of them are on digital interventions. And I will give you now some examples of projects in which I have been involved and in which I think are very promising. Well, this one is also on prevention, and I showed it also in my previous slide. This is a very good example of how you can use digital interventions to prevent the onset of major depression. So we randomized people to guided self-help, problem solving and behavioral activation of usual care. People didn't have a diagnosis at baseline, and we looked at the incidence at post-test and found that the incidence was significantly lower in those who got the intervention compared to those who didn't get the intervention. This is a project led by Tara Donker in our group. And what she did, it's not on depression, but it's an acrophobia, fear of heights, where she developed a VR application with these carbon box VR application. So you put your phone into a carbon box and then you have a VR glass, so to say. And it's very cheap, but you can use your own phone to use it. And it's very affordable. She's doing this now in all kinds of other anxiety disorders. And well, in the intervention, it's based on exposure. You have an elevator which you can use yourself, and where you can go up and down. So you can and you handle that yourself, how high you are, so to say. So you can do the exposure in steps yourself. And this is one of the screenshots. And this is where you stand on a building when you are very high at your exposure level. And it was a pretty large trial, and it was really very effective in terms of fear of heights. Okay. And then we go to the IPD, individual patient data meta-analysis, led by my valued colleague Irini Kariotaki. And she did all kinds of large individual patient data meta-analysis in which she collected the primary data of randomized trials and merged them into one big data set to see how effective these interventions are, but because you have the primary data, you can also examine who benefits from the intervention. And these moderators of effectiveness, you cannot use that in normal randomized trials, because these trials always have the statistical power to find an effect. While in order to find moderators, you need much more participants. So single trials are never capable of finding moderators, hardly ever. But when you put everything together in one big data set, you can examine moderators. And this is an example of a very nice IPD meta-analysis she led on self-guided digital interventions, so without any human support. And she found that these interventions do work, but the effects are much smaller than those of guided internet interventions and individual, group, and other therapies. This is the other one on guided interventions. So that's another IPD meta-analysis. And then in 2021, she merged these two data sets. And then she did an individual patient data network meta-analysis. So people could have nothing in a control group. They could have guided internet intervention or an unguided. And she could compare all three in one big network meta-analysis. And I won't go into the details of that, but this is a website. You can go there. You can fill in all the details of one particular patient. You have to fill in baseline severity. You have to give the age. You have to give gender, etc., etc. And the variables you see at the left of the screen are those that predict the outcome. And so you can see for each individual what the exact outcome will be of the guided intervention, the unguided intervention, and how they relate to each other. And I think this is a major step towards personalized treatments, because here you can see who needs guided interventions and for whom unguided interventions are good enough. And overall, it was clear that unguided interventions and guided interventions, it makes no difference in people with less severe depression. It's only when people get more severely depressed that they need guided interventions. Well, and these IPD meta-analysis also have the advantage that you can look at rare outcomes like deterioration. Usually not many people deteriorate during a treatment, but there is a small group of people who do actually get worse. And in all these meta-analyses, we found that the number of people who really get worse is smaller in the ones who get the intervention compared to the control group. So that's good news. But digital interventions are, I mean, we have this basic knowledge that digital interventions are effective. No difference with face-to-face interventions, but we do not know how to apply it. And that doesn't mean that it works anywhere for anybody at all times. And that's why I find it also important to give a few failures of the trial. So I've been doing 35 randomized trials in this field, and I showed you the nice ones with, you know, high papers and very good journals, etc., etc. But there's also another side, and that's very important in this field, because we don't know if it works in each specific setting. And here, for example, we had at one time, we got a few very large grants to examine if people on the waiting list for specialized mental health care who had a depression, and then in another project, we look at anxiety disorders. So while they're waiting to get treatment, why can't we give them already a guided self-help intervention? The idea was that a lot of them would wouldn't need treatment at all anymore. And if they would get treatment after that guided self-help during the wait list, then the number of sessions would be much lower, so it would be cheaper anyway. So we did these two large trials, and yeah, basically we found it doesn't work like that. People don't feel they got a real treatment during the waitlist. Guided self-help is not the same as seeing somebody in person. And the therapist afterwards, they just did what they usually do, and they didn't reduce the number of sessions. So it was not cost effective at all. In another trial, we developed an online digital intervention based on problem solving for Turkish people in the Netherlands. And it was not very difficult to recruit people, and it was not significant. The same in an internet-based preventive intervention for employees in large companies, not effective. So what I think is important is to realize that digital interventions work, but we really have to examine if it also works in this setting, with this population, in this context. And then I go to global mental health. And so when I think, as I said in the beginning, when you think of global mental health, you really have to think in a different way. So for treatments, we are very happy that digital interventions have the same effects as face-to-face interventions. But for global mental health, it really doesn't matter that much. You have this, so there are, for example, more depressed people in China than the whole population of Spain. And there are more depressed adolescents in India than the whole population of the Netherlands. So think about the numbers of people we're talking about. And when you want to build up mental health care for people with depression in China or for adolescents in India, how can you even start to think about how to develop such an infrastructure? So if we can develop interventions with only a tiny effect, but we can reach a large part of the population of depressed people in China, that will have a major impact. It will easily have a larger impact than everything we do in Holland in the total mental health care together. So you have to think, when you think about global mental health, you have to think differently than what we traditionally do. So what I think is you can have different levels of interventions in low and middle income countries. You can start with unguided digital interventions. They work. The effects are small, but they work. There will be a lot of people who won't use it, but it's 800 million people in low and middle income countries who have mental health problems. So even if a fraction of those use it, then the impact is still large. If you have more money in a country, you can start with guided digital interventions, which have large effects, as we've seen, which are more expensive, as you can imagine, because you have to have personal coaches. But you don't have to do that through the internet. You can also print books and call people by telephone. That works in exactly the same way. If you have more money, you can start with lay health counselors in primary care centers, where you train people to deliver psychological treatments. And then you get to the next level, where what we have in high-income countries in Northern Europe, that you have treatment by trained professionals. And so this is one of the, we did one big trial in Lebanon in people in Syrian refugees and in other people living in Lebanon. It was one big randomized trial, but we stratified across Syrian refugees and other people in Lebanon, so that we had enough people in each of these two groups. So one of them was published in last year in Evidence-Based Mental Health, and the other in PLOS Medicine. And what we I don't know if you know Lebanon, but there is a lot going on. The political situation is very complicated. The economy is really very bad. They had this blast in the harbor of Beirut, which was devastating for this whole area. They have had several wars, and so it's a really a lot of adversity in this country. And so what we did is we used the WHO intervention and made a smartphone version of it, which is called Step by Step. And this was also done in collaboration with my colleagues Maret Sibrandi, who leads the Strength project on Syrian refugees in Europe and the Middle East. And so we trained non-specialists in Lebanon to deliver step by step the digital intervention, which was really adapted to men, women, traditional or modern, and so people could choose how that looked, how it looked like. And we compared it with usual care. People had to be depressed. It was a large trial, but also the dropout was large, almost 1,200 people. But the dropout was also very high. But we found pretty good results. And if you look at these outcomes, this is very, very much what you would get from normal treatments in the Netherlands for treatment for depression as well. Pretty good effect sizes, so this was all very good. Okay, the future, digital interventions. So in many ways, the internet interventions that I've talked about, they're actually pretty old-fashioned. So the idea was, I said it started in the 1960s. And what happened since then is that people looked at what happens in face-to-face therapies, and they wrote it down in a book. And when you write it down on the internet, you adapt it, you make it shorter, you make these nice graphs and videos, etc. But the principle is the same. You take face-to-face therapies and turn them into digital internet interventions, and they work. But if you look at how digital tools are used nowadays, people don't do that on their phone, do they? When you have a smartphone, you look at it 100 times a day, and you look at it for 30 seconds per time. And maybe if there's something interesting, you look 40 seconds, but then it's over. But our digital interventions are not like that. They just assume that you have to learn about cognitive restructuring, that you have to do behavioral activation to make a difference. And so and how do we adapt these interventions to the smartphone? We don't know. And there's a lot going on. There's a lot. There is an increasing number of trials, so that's good. But the number of apps which are not tested is much and much higher. So there's lots of apps. People try to get money off it, and we still don't know if they work and if they really have an impact. And so it's a bit of a gray area. We just don't know whether this will really make people better. We don't know. And then we have big data and artificial intelligence. And I think we have no clue on what the impact will be. Can we use that for unguided interventions? I've tried it myself. I asked ChatGPT a few things about, I'm depressed, what should I do? And I got a complete list of advices that you would find in any self-help book as well. And I asked about, okay, behavioral activation, how does that work? I got a very nice, extensive explanation of how it works. So will this make a difference? We don't know. But and this is true for anything I've said, if it works, then of course I'm very happy. But over the years, I've seen also too many promises to believe that all these new things do work. But I really hope it will. So I come to my conclusions. There's no doubt that internet interventions are effective. And they are just as effective as other treatment formats. The challenge will be, how can we implement that in all these settings where we can use them? We need a lot of creativity. We need a lot of trials and possibilities. But we also have to remember that this whole field is changing enormously fast. The change is rapid, and it's almost impossible to keep up with all the... We need new designs, because when you do a randomized trial, that takes 3-4 years. But 3-4 years in terms of apps, that's an eternity. These apps have changed so completely compared to when you started with a trial, that you have to adapt your design during the trial. But however you look at it, there is no doubt whatsoever that for the coming decades that the internet and digital application will have a huge impact on mental health care. Thank you for your attention.